Good morning. I'm Bonnie Gardner. I'm co-chair of the Public Affairs Forum of the First Unitarian Universalist Church of Austin at 4700 Grover Avenue. Welcome to our Public Affairs Forum. Our forums are on Sunday at noon, and they're free and open to the public, and we encourage you to attend. Today, it's my honor to introduce Ann Dunkelberg, who's going to be speaking on the Affordable Care Act. Ann is a true healthcare policy expert, nationally recognized, and she's Associate Director of the Center for Public Policy Priorities of Austin, Texas. So she's going to give us an overview, explain implementation, and the expected impact on access to health care. And this legislation is taking our nation one step closer to making comprehensive health care available to almost every American and on a sliding scale fee. Ann has worked for the Center for Public Policy Priorities for over 19 years. Prior to joining the Center for Public Policy Priorities, she was Program Director in Acute Care in the Texas Medicaid Director's Office. That's a daunting job in and of itself. She also worked with the Texas Research League. She's authored many reports on Texas health and human services and budgetary issues. She was a magna cum laude graduate from UT and has earned a Master of Public Affairs from the LBJ School of Public Affairs. She's been named Consumer Advocate of the Year by Families USA in Washington, D.C. in 2007. 2008, she was honored with the LBJ School's Alumni Association's Distinguished Public Service Award. We're really lucky to have her here, and so without further ado, I want to let her take over and tell you all about it. Thank you, Ann.
Thank you. I appreciate having this nice platform to stand on. And y'all, if you see me walking backwards, warn me, as I fall off. I appreciate the invitation to be here, and it's what I'm going to try to do is, while I'm a supporter of the Act, this is not specifically a cheerleading presentation. I really want to give us the opportunity for you guys to get any questions that you may have answered, and we can talk about some of the things that have been, coming up in the news quite a bit lately. So let's see how we go here. So I'm going to give you a little bit of context first. So this is the latest census data that was just released in September on our uninsured. We have about 6.4 million uninsured in 2012, the latest year the census has counted. And obviously one of the big takeaways from this slide here for Texas is that the vast majority of our uninsured are working age adults, 19 to 64. And one of the things that's interesting and often ignored is that our kids, our 0 to 18 kids, have an uninsured rate today that's about half what it is for working age adults. And that is entirely, and if you think about that, well, kids are a lot less likely to have coverage through employment than adults are, right? I mean, the employer might pay for your coverage, but very few Texas employers contribute anything toward dependent coverage. So why do kids have half the uninsured rate? It is entirely because of having children's Medicaid and the Children's Health Insurance Program. And one of the things we'll touch on is that we simply don't have a public parallel to that for low-income adults, and we'll see what some of the consequences of that are going to be. I had a couple of presentations lately to, some Latino health forums and those sorts of things, so I brought a couple of the slides that I was specifically asked to do by those guys. So this is what our uninsured Texas children for 2012 look like by ethnicity and race. And I'm sure you won't be too shocked to see, you've probably all heard that we already have a Hispanic majority in our K through 12 public school population. So the child population is much more Hispanic than the overall all-age population is. So nearly 70% of our uninsured kids in Texas are Hispanic, and then with the non-Hispanic white children being the second largest group, African-American children, and then the other groups that we have in there. This is what our working age adult population looks like, not quite as heavily Hispanic, but still more than half of that population being Hispanic. So the uninsured rate for Texas kids has dropped substantially back in 1998 when Congress, or 1997 when Congress authorized the creation of the Children's Health Insurance Program. But before it existed anywhere, our uninsured rate for Texas kids was around 25%, just about exactly what it is for the whole population of all ages right now. And we finally got our CHIP program up and running in 2000, and since then, Medicaid and CHIP together have added, we went from covering just under 1 million children in May of 2000 to today, when between the two programs we're covering 3.1 million Texas kids. And the overall uninsured rate for kids has dropped from 25% in 97 to 16.4%, again, because of these two programs. And if you look just at the income population that actually serves Medicaid and CHIP, which is below 2 times the poverty level, that uninsured rate for those very low income and poor kids has dropped from 35% in 97 to 21.4% in this latest year. So it's still really unacceptable to have 1.2 million uninsured children, but the uninsurance rate for that group has been dramatically reduced because of these public programs. You're probably familiar with all of these sort of big overview features of the Affordable Care Act, many of which have already started taking effect. We've ended lifetime and annual caps on what arbitrary caps on what a plan would pay out. Starting in January, no one can be denied based on pre-existing conditions. No one can be charged more based on existing or pre-existing health conditions. Preventive care that's medically recognized as being valuable has to be provided in most plans without any copayment. I don't call it free because you're paying for it as part of your premium, but you will go get it without having to put up an out-of-pocket cost, and the idea being that you're a lot more likely to go and get that colonoscopy you're so excited about if you don't have to also put up hundreds of dollars out of pocket for that exciting experience. And I was able to get my first colonoscopy, a year or so ago without any out-of-pocket costs because of that, which did make it slightly less unpleasant. You have a situation starting in 2014 where all plans have to cover, to some degree, these categories of benefits called essential health benefits, and we'll talk more about them. And we started the closing of the Medicare prescription drug donut hole in 2010, and it closes down a little more every year. We have some insurance regulations that have already taken effect, the so-called 80-20 rule, which resulted in many millions of dollars being refunded to Texas consumers a couple of summers ago as premiums 80% or more of premiums collected must be paid out either in the form of actual health care or the kinds of administrative services that serve health care, like, say, nurse helplines and case management, that sort of stuff. We have a little bit of rate review going on. It's not very much because the ACA still depends on states to regulate health insurance in certain ways, and Texas has essentially chosen not to regulate rates in the health insurance market. And the coverage expansion, of course, we're really waiting for January 2014 for that to start actually taking effect. And that takes place in both an individual and family marketplace or exchange that you've heard about. In every state, there will also be a small business marketplace that's sometimes called the shop. And then we've heard about unfortunately the sad situation with our Medicaid expansion, which was intended to pick up everyone just above the poverty line, at least who was a U.S. citizen or lawfully present. We will talk more about that. So who are we talking about? This is from Enroll America, but it's based on census data. And basically what they're trying to get across to you here is that you've got a big chunk, maybe 41% of the uninsured nationwide, who would gain coverage only through the Medicaid expansion. Another portion of the uninsured, 37% nationally, could get coverage through the new marketplace and qualify for some help there. Another 9% of the uninsured are above the income limits for the new marketplace for getting any subsidies. In other words, they're moderate to well-to-do folks. They can get coverage in the marketplace. They're just not going to get a subsidy. And then another 13% nationally of our uninsured are not eligible for help in the marketplace due to immigration status. And what that means, they're being very polite at Enroll America. What that means is that they're not lawfully present, because people who are lawfully present do have access to the new systems. So the marketplace, which will actually start delivering coverage in January, but as you know, has started a very slow rollout of open enrollment on October 1st. essentially is supposed to be a place where we can compare private insurance plans, and I think we emphasize that because it's basically all of the commercial insurers that you're used to hearing about are participating in that marketplace, as well as some new players in Texas that we'll touch base about in a few minutes. Most people who can buy coverage in that marketplace are going to get a break on their cost. There is a rule that says there's no wrong door, so if I apply to the marketplace but I'm really low enough income that, say, my kids should be going to Medicaid or CHIP, the marketplace has to send my information directly onto the state, and those kids are supposed to get directly enrolled, and vice versa. If I apply to a state Medicaid program and my income is too high, they have to automatically send my information to the marketplace so they can review and see if people in my family qualify for benefits there. And I think you probably all know about those deadlines, or about the opening date for the marketplace. You'd have to have been asleep lately to have missed out on that. And the earliest coverage can take effect is January 1st, but the open enrollment period extends all the way to March 31st. One of the more confusing developments of the last few weeks was what the media reported in 1,000 different ways, but basically what they said was, there had been some concern that because it takes a while to both pick a plan once you find out you're eligible for coverage, and then usually when you sign up for insurance, they say, okay, your coverage starts the first of the next month. And so they were afraid that people really wouldn't be covered and avoiding any kind of penalty for being uncovered unless they actually signed up sometime in the middle of February. And the federal government basically said, we have enough flexibility and we have enough problems with our website that we're going to make darn sure that anybody who enrolls by March 31st is going to be protected from any penalty. So this marketplace business, it's easy to feel like Texas is the only recalcitrant and conservative state out there that's not participating in the Affordable Care Act, but that's not the case. We're one of more than 30 states not doing a full-fledged state-operated marketplace, which has turned out to be unfortunate for us because the state marketplaces have all been operating much more effectively than the federal one in terms of their websites, probably because they were taking on a much smaller task than the federal government was. So you can see Texas and all the other beige states are states that are using the federally facilitated marketplace, and that's the one that operates healthcare.gov and that has been having so much trouble over the last few weeks. So who can get coverage in the marketplace? The thing to understand is that it is true, and we'll talk about the little kerfuffle this week about whether or not people were able to keep their plans if they like them, and we'll parse that a little bit in a minute. But the point is the marketplace is not intended for anybody who already had a good, affordable, employer-sponsored plan. The ACA assumes that everybody with good, affordable, employer-sponsored coverage keeps their good, affordable, employer-sponsored coverage. The marketplace is primarily designed for people who are uninsured today or who are buying coverage directly from an insurer. And that is usually referred to in the WONC world as the individual market, or just in the insurance world, and it is by far the most dysfunctional part of the whole health insurance system, and in Texas is completely unregulated in terms of rates. There are literally no limits whatsoever on what you can be charged in the Texas individual marketplace. Some states regulate much more than Texas does, which I'm sure won't surprise you. But basically, anyone who's a U.S. citizen or a legal resident of the United States can buy coverage in the marketplace, but you cannot be incarcerated, or at least you can't be incarcerated after having actually been convicted. But there's a difference between being able to buy coverage in the marketplace and qualifying for financial help in the marketplace. So the second row up there shows you who qualifies for financial help. And you have to basically have an income under 4 times the poverty level, and we'll see some examples of that in a minute. And you have to be not eligible for other minimum essential coverage, which means if you have good, affordable, employer-sponsored coverage, you don't get to drop it and go to the marketplace. There's some provisions that are intended to allow people who are getting a really bad deal from their employers to go to the marketplace and get subsidies, but they are flawed provisions at this point, and we'll talk a little bit about that too. So people who get help, there's 2 kinds of help. There's help with premiums, and there's help with out-of-pocket costs. And the law and the wonks call them advanced premium tax credits, and I call them help with your premiums, or financial help with your premiums. So basically, who qualifies for that? You have to be under 4 times the poverty level. There is an exception that allows people with green cards to actually access that help with their premiums, even if they're below the poverty line, and that's because people who get a green card are excluded from Medicaid in the United States for the first 5 years that they're here under federal law. And then there's also another half a dozen states that don't let people with green cards get Medicaid even after they've been here for 5 years. And guess what? We are one of those 6 states. So in Texas, we need that provision both for the people here in their first 5 years in the United States and for people here after that. One of the ways that other people can get access to that financial help is if you work for an employer who's making you pick up such a big share of the premium for your plan that it actually takes more than 9.5% of your own income to get your own policy. So if my policy, for example, if my share was more than 9.5% of my income, then I would be allowed to go to the marketplace and could qualify for help with the premiums. So what do these subsidies look like? The way they're set up is on a sliding scale relative to your income, and the people who are close to the poverty line, between the poverty line and say 1.5 times the poverty line or 150% of poverty, they get the most intensive kinds of subsidies and pay the least out of pocket. So the table up there in the upper right-hand corner basically shows you that the subsidies start around $11,500 for one person a year, and they would not be available to a single person earning $46,000 a year or more. So it's in that range, but really, really concentrated towards lower incomes. And we'll show you a couple of examples. Now, in addition to that, I can apply for out-of-pocket cost reductions, and the cutoff for that is lower. It is 250% of poverty, or 2.5 times the poverty line. And basically, if I fall in that income range, I'm not only going to get a lower premium, but I'm also going to bring down my co-payments and deductibles, which could be extremely valuable to me. And it is designed to fit with or be applied to a so-called silver level plan, which we're going to talk about in just a second. But the simplest way to think about a silver level plan, which will make sense if you've had insurance and might not if you haven't, but is that it's sort of a 70-30 plan. A lot of us have insurance that's about 80-20. We expect the insurer is going to pay about 80% of our costs, and we may have to pick up about 20% of our costs. The silver plan is more like a 70-30 plan. These are some sample premiums for a family of 4, and these are from the Kaiser Family Foundation, and they are these are from the Center on Budget and Policy Priorities. A lot of people contributed to this today. And they're national averages for a family of 4, but I mostly wanted to show you how much that maximum monthly premium, which is that second column from the right, how much it goes up as you move up the income scale. So if I am a very low income working family living on $23,000 a year for my family of 4, I may be able to pay less than $40 a month for the premium for all 4 of my family members. But as I move up the scale, that goes up fairly quickly. So by the time I get up to an income of around $47,000, I'm paying around $250 a month. So it does move up quite quickly. It is quite substantial, the subsidy, when you're at those lower income. And you can see that some of our families in this scenario are also qualifying for cost-sharing reduction. One of the pieces that also goes with the Affordable Care Act, that because there's so much for us to wrap our minds around, we often don't even get around to talking about, is that it also brings in some hard caps on out-of-pocket costs, and they are set in federal law, and they will be indexed to inflation and go up every year. So for 2014, the maximum out-of-pocket cost, and they're not counting the premium contribution you make in that. They're talking about co-payments, deductibles, and co-insurance. So the most that you can have to spend out-of-pocket in 2014 under any regulated health insurance plan is going to be $6,350 or $12,700 for a family. And you can see that your folks who have the slightly lower incomes, below 2.5 times the poverty level, that out-of-pocket limit for them is a little bit lower. So not only are you going to get a lower deductible for your prescription or your visit to the doctor if you're in that income range that gets that help, but you're also going to have that lower cap for each year also to fit your income. So my husband and I together could have to spend in 2014 as much as $12,700 on out-of-pocket costs, and we would certainly see that as probably a bad year for our pocketbooks and our health care if something came up to generate that kind of out-of-pocket cost. But at least in my situation, that would guarantee that it's not going to bankrupt me. So it's not going to completely eliminate medical bankruptcies by any means. It should reduce medical bankruptcies quite a bit. So here's who's in the Texas marketplace. We have 11 insurers who are participating so far. And I've listed them there just in alphabetical order. Those are the ones that are in there. One of the interesting things, you'll recognize some of those names, obviously, as names that you've heard of and perhaps been covered by. One interesting thing in Texas is the plans that have a single asterisk are all community-based nonprofits, so they're literally nonprofit corporations. All of them are plans that all of them except Scott and White are plans that started out as plans that serve Medicaid and the Children's Health Insurance Program. Scott and White has been a nonprofit health plan for quite some time. And then you see Blue Cross, which has 2 asterisks. It's technically not a nonprofit anymore in the legal sense of a nonprofit corporation. It converted from that status over a decade ago. I forget the exact year. But it's called a mutual plan and is policyholder owned. So it's kind of in a status all by itself. And I think it's interesting to watch those things, but I also think it would be a mistake to immediately assume that all the plans that are nonprofit are going to be great and, and really do a good job, and that all the for-profit ones are going to do a bad job. But I do think it's something that's going to be very much worth watching to see how they perform differently. Now, I'm going to show you a couple of more examples. These are actual Texas premiums. These are from Houston, where the costs are somewhat higher than they are in Austin. But I want to show you just a little bit about some of the differences between qualifying for help with your premiums at different ages and at different incomes. So this whole table here is a 27-year-old in Houston. And if he has a very modest income of living on around $15,000 a year, then he's going to qualify for a subsidy of $162.90 a month. And there's a formula. The formula for them calculating that is they figure out what the second lowest cost silver plan is in your, where you live. And then they apply, they say you're not going to have to spend more than X percent of your income. And in this guy's case, I think X percent of his income, I wish I'd put it on the slide, I think it's either 2% or 3.5% of his income is the most that he can pay. And this is a sliding scale. So as my income goes up, that percentage goes up. And so they figure out, okay, here's what X percent of his income is. We'll say 3.5 and do the math later. That's the subsidy he gets. And he can now take that subsidy and apply it to any silver plan or any bronze plan that he wants to. So basically, if he applies that to the second lowest cost silver plan, then his premium is only going to be $38.20 a month. But he also has the option to apply it to a bronze plan. Bronze plan is a 60-40 plan. So that's a plan where you've got a lot more potential out-of-pocket costs. You're saying, I think I'm going to be healthy. I don't use the doctor a lot. I don't take a lot of prescriptions. I'd rather have a lower premium and take the risk of paying more when I go to the doctor or go to the pharmacy. That's the trade-off you're taking if you do bronze. And so he may decide if he applies that $162.90 to the bronze plan, it's actually more than the premium for that plan, and so he doesn't have to pay any monthly premium. So a lot of young people are going to be tempted to do that, and it may be the right choice for some of them. It obviously exposes them potentially to a lot more out-of-pocket costs if they have an unexpected illness or injury. That's the downside. And so some people are already starting to refer to this as the bronze trap. And it's one of the things we'll have to do a lot of consumer education about is sort of, this is your big trade-off. You got to decide, the trade-off between a low monthly premium versus potential exposure to more out-of-pocket costs. And you can see how the premium he pays for the second lowest cost silver plan after subsidy goes up, and once he gets to about 3 times the poverty level, he's actually, the percentage of his income that applies is actually higher than the premium itself, so he's no longer actually getting any help with his premium. He's paying the full premium. And again, the bronze is going to be attractive to him there because it's the lowest premium he can look at. Now, what happens when suddenly our purchaser is 40 years old in the exact same community? Well, the bad news is, good news is, under the Affordable Care Act, the care in the marketplace is no longer priced based on your health or in the case of a small business, the line of work you're in. For a small business, the rate's going to be the same if you have 2 employees as if you have 48. So some of the kinds of discriminatory practices in rating, there's no gender difference anymore. But, of course, the health status and health history is the big factor that's gone away. But age is still there. So I can be charged, it's actually on a sliding scale. If I were 64, I could be charged 3 times as much as a 20-year-old. And so you will see those differences. But today, I can be charged like 10 times what a 20-year-old is charged. So it's, even though, I'm not excited about paying 3 times as much as a 20-year-old, it's actually a tighter sort of band of rates that are allowed than we have under current law. So now that we've gone from a 27-year-old to a 50-year-old, you can see once again that the price that I'm going to pay is just based on my income, not my age. So if I am older and I have a really low income, just like the 27-year-old we were talking about, I'm still only going to have to pay $38.20 a month. And because the premium for somebody my age is so much larger at $245, then the subsidy I'm getting is actually bigger. So yes, as older people, we're going to be exposed to higher premiums than younger people, but if we happen to be older and of modest income, we actually are potentially going to get a more generous subsidy than a younger person as well. And here finally is the 64-year-old example, and you can see how the lowest cost silver plan at age 64 has gone all the way up to $575. It was around $200 on our first slide for the 27-year-old. So again, if I have low income, the monthly tax subsidy that I get is going to be quite large relative to the price, and the temptation to go with the bronze plan may still be there because, again, I can have no premium payment, but then potentially exposure to out-of-pocket costs. So I spent a lot of time on that, but I think it's probably a lot of you have heard the basics enough times that getting into, this level of detail is probably helpful at this point. So we already looked at one of the main differences between plans, one of the big differences and one of the big decision points, again, that you're going to make in the marketplace if that's where you're going, is between, lower premium versus higher out-of-pocket costs. And the Platinum plan is one where if you averaged everybody in that plan who's enrolled in it, that on average the insurer would be paying 90% of the health care costs and the enrollees would be paying 10%. So these ratings are not individual to you. You're not going to be able to go back to your policy and ensure that you individually had a 90-10. It's for everybody in that plan. So that's going to be one of the main differences and one of the main decision points. And there's also a fifth level, which is a catastrophic plan, which presumably is going to have even lower premiums. And it's available to anybody under 30 who wants it and to anybody who, through all of the catch-22s and exceptions and things that don't work well about this law, finds themselves in a situation where even in the marketplace the best deal they can get is more than 8% of their family income, then they automatically are allowed to buy catastrophic coverage if they prefer, if that's their choice to do so. They're also exempt from any penalty if they stay uninsured. One of the big things that is different about insurance in 2014, and it does play into this whole discussion about if you like the coverage you have, you can keep it, is the inclusion of essential health benefits. And so nobody can sell coverage in 2014 that doesn't cover these basic kinds of benefits. And this is, I will warn you that this is not micromanaged at all. So we're still going to see variations in coverage, and we're still going to see attempts by insurance companies to control costs in these areas. But no one will be able to sell plans that don't cover maternity or don't cover hospital care, both of which are surprisingly common today, nor can they sell coverage that doesn't cover prescription drugs or coverage that doesn't cover mental health or substance abuse disorders and treatment. In addition to that, I won't go into a lot of detail on the mental health and substance abuse area, but in addition to the essential health benefit requirement, you also have a new and heightened level of parity requirements going into effect in 2014, and so that means that you're not going to be able to have arbitrary limits on mental health that aren't the same kinds of limits that you have for other medical services. So we should be seeing some improved access to mental health services for people who have coverage. starting in 2014. The other services are listed there. I would point out to you that only children are required to have coverage with vision and dental included. So we adults are on our own with our teeth and our vision at this point. This is the way the marketplace, was a fixed graphic, so I couldn't go in and put quotation marks on works like I wanted to when I first used this slide, but this is the way it's supposed to work. And I will tell you that last Saturday, so I got trained as a certified application counselor. I'm volunteering with Foundation Communities. They have a site at Highland Mall, and did some shifts the first day it opened and the day after, and then went back last Saturday, and I was thrilled when I was able to go all the way through the process of setting up an account and getting in all the information. So I can tell you they're making progress. I believe that they are not done because obviously the system shut down twice this week or something, but it is progress, because I can tell you on that first day we couldn't do anything on healthcare.gov, and now I was able to very easily go through with this woman and set up an account and really get everything input, except she had a couple of documents. You don't have to provide a lot of documents, but if you are a green card holder, they do expect you to actually scan your legal resident card and upload a copy of it. And she had 3 people in her family who had those cards and only had one of them with her, so we couldn't complete her process. So I'm very excited to see where we go with this. But that basically, we should be able to go through all of these steps, and I think picking a plan is probably the hardest part. A lot of people would not be able to do all of that in one sitting because there's just a lot to consider, and absolutely people need to, if they have a doctor or a clinic that they really want to stick with, they really need to get on the phone with those providers and confirm that they are taking a particular plan. So that's going to be a challenge. I hear that this young woman's face has now been taken off the website. I'm sure she's relieved. But in any case, this is the website. There actually is an amazing amount of functionality on this website, while there are many things that don't. I will go ahead and take 30 seconds to just talk about one of the things that probably has not been recognized a whole lot in the dialogue and in the media coverage on this is I don't think that there probably isn't any website in the world that's expected to have this kind of volume and this level of interaction with different databases. I think that's been kind of underplayed. I think there are probably some military and very tightly controlled websites that have extraordinarily sophisticated interactions in the space program, in the military, those sorts of things. But this website has to be able to. It's not just like buying a plane ticket. It's, unless you have to verify your income and your citizenship to get a plane ticket, and unless you need to be able to interact directly with every single airline's ticketing and overlay a sliding scale of different prices based on your income. So you see what I'm saying? It's like there are it has to interact with the Social Security database and the IRS and Homeland Security, and last time I checked, every one of those systems has been plagued with its own problems for years. So I'm crossing my fingers that they're going to be able to get all those interfaces to work and work well soon, because I really, really want people to be able to, have that functionality. But I'm not surprised that there have been difficulties. And of course, there have been difficulties. This has been implemented in an atmosphere where there hasn't been wholehearted support. I want to just mention to you that we had very little direct action on the Affordable Care Act in our last Texas legislative session, partly because our leadership was kind of hardening around and particularly the governor's office, sort of hardening around a symbolic, we're not going to do anything to cooperate with the implementation of the ACA. So we did, for example, we put a bill in that said that if the federal navigator standards for helping people enroll were inadequate, that we could add some additional state standards. And TDI had told us about 2 months ago that they didn't plan to do any rules on it, but then the governor sent them a letter in September. The governor also sent a letter to the Medicaid program saying he wanted to keep collecting information on people's assets in Medicaid, their bank accounts, and their other things of value. And he also directed the health department to stop, even though we passed a bill sponsored by Senator Jane Nelson, not known as a wild-eyed liberal, telling DHS that to inform all the applicants for their public health programs about the marketplace, because they reduced all of those programs' budgets by $30-some-odd million on the assumption that those people would enroll in coverage and wouldn't need these direct public health services anymore. So it made sense that they were going to make part of their job helping people enroll. Well, the governor told them to shut that down and stop helping people. So we've got a real pushback happening from our governor's office right now. Part of that, as you may have heard, as I just alluded to, is around the role of navigators. It's important to understand that under the law, a lot of different people can help people enroll. We've got agents and brokers who can help people, and especially we expect will continue to play a big role with small businesses. Navigators, which are organizations that have gotten a direct grant from the federal government to help people, and they have a much higher level of training, complexity of training. They need to be able to help people with small businesses as well as individuals and families, as well as Medicaid and CHIP. And then there's certified application counselors who you can't freelance on that. You have to be affiliated with an organization that has permission from the U.S. Department of Health and Human Services to do application counseling and has overseen your training both online with the feds and direct training and any other kinds of security requirements that go along with that. And then we have, again, this is kind of wonk speak, but federally qualified health centers, sometimes referred to generically just as community health centers. We have a couple in our Central Texas area. One is the community care clinics that are run by Austin-Travis County, and then we also have Lone Star Circle of Care. All of the federally qualified health centers in the United States got special money to allow them to staff up and train people to be certified application counselors and to help people sign up. So they are a great resource in Texas and in the rest of the country. I'm not going to get into a lot of detail on this because we should probably wrap up soon and just take some questions, but I did want to let you know, again, there's a difference between navigators and certified application counselors. There's a lot fewer navigators because the federal grant money only went so far. We got about just shy of $11 million in Texas for navigators, and then the federally qualified health centers got almost $10 million for their application assistance stuff. But all the other folks, like your foundation communities and stuff like that, who are doing certified application counselors, they're doing that from other funding sources. A lot of them went out and sought grants, from foundations and other folks to do that. Individual mandate, we should talk a little bit about that, that basically if you have job-based coverage, Medicare, Medicaid, CHIP, VA access, because VA access is not really insurance, it's access, TRICARE, which is insurance, a plan that you bought in the marketplace, or if you buy an individual plan directly from an insurer, any of those things satisfies the individual mandate. It phases in over 3 years, and so this chart up here shows you how it phases in, starting at $95 per adult in 2014 and going up to almost $700 an adult in 2016. There's a lot of folks who are exempt from an individual mandate, so anyone who's uninsured for less than 3 months out of the year is going to be exempt, and my suspicion is we'll see more flexibility for that in 2014 because of the delays in the marketplace functionality. Anyone whose income is more than 8% of their whose premium costs would be more than 8% of their income, as I mentioned earlier, is also exempt from any kind of penalty, or can have that choice to buy the catastrophic coverage if they prefer to do that. Anyone whose income is low enough that they don't have to file income taxes, which is not a number most of us carry around in our heads, but if you look at the instruction book for the 1040, which you can easily Google, there's always a little table. You will recognize it when you see it that says, who has to pay taxes? And there's a little table that shows you household size and income thresholds for filing taxes. So people whose income is low enough that they don't file taxes are also not subject to any penalty. Anybody who's in a state that has an expanded Medicaid, like Texas, is specifically exempted from any penalty as well. So if you're uninsured because your state didn't expand Medicaid and there's no coverage for you in the marketplace, which we'll touch on quickly in a minute, then you don't have a penalty. Other exemptions include things you might expect, like there's some religious exemptions, some Native American exemptions, those sorts of things. I think I've preemptively talked about most of this stuff already, so I'm going to go on touch on a couple of things about Medicaid expansion and then take your question. There are a bunch of things that every state has to change about their Medicaid program, even if they're not doing even if they haven't elected to do the Medicaid expansion yet. Most of that stuff's probably too wonky for us to get into, but I wanted to slap that up there, and any of you who have questions about it, I'd be happy to talk about it later. I want you to understand who's in our Medicaid program in Texas today. As you can see, it's mostly children. So you've got almost 2.6 million children in Texas Medicaid, about 600,000 children in the Children's Health Insurance Program. Then the two largest groups of adults in Texas Medicaid are fully disabled persons. These are adults, most of them below the poverty line, seniors below the poverty line. So they're getting both Medicaid and Medicare. Medicaid's picking up all those giant out-of-pocket costs that Medicare has. And then you have, as you can see behind me, just a couple of little slivers for parents. So right now, I think in the most recent month, there are around 200,000 parents getting Medicaid in Texas and 2.6 million children. So the vast majority of the children in Medicaid's parents don't qualify. And then we have maternity coverage, which is a whole separate category. You don't get it until you've got that positive pregnancy test, and it goes away 2 months after the baby's born. So it's a temporary coverage. It's very important in Texas, even though it's only around 90,000 women per month. That ends up paying for about 56% of the babies born in this state. This is just to show you how you end up with 2.6 million kids and only 200,000 parents. So the income caps for kids are much higher. They are at the poverty line and above, depending on your age, whereas the parents, through a fluke of congressional decisions over the years, they just never set the bar anywhere, for the last 30 years, basically. So Texas, literally, if I were a mother with 2 kids, and let's say I've just gone to the domestic violence shelter, so I'm not working right now, but my parents are giving me a little money. My parents couldn't give me more than $188 a month while I'm in the shelter for me to keep my Medicaid as a parent. If I go to work, though, I get an earned income disregard today, so I could make a whopping $308 a month and still keep my Medicaid. But that is literally the limit. And the reason for that is that our legislature set this income limit in 1985 as a fixed dollar amount, and it's never been updated since then. It's not pegged to inflation. It doesn't have an update. It's literally the same dollar amount that it's been the entire time that I've been studying health care and doing this work. And that's how we ended up where we are. And just to refresh your memory, we don't cover the undocumented at any age, and we're one of the 6 states that also doesn't cover legal immigrant adults. Now, we are not the only state. Again, we may feel like we are the worst, but we're not alone. Texas is the 5th bar from the left there. It's sort of a darker blue. I keep forgetting to try to go in and change that to red so you can actually see it. But there are a number of other states that have very, very low income caps for parents as well. And so the decision, you will sometimes hear the media oversimplify it and say that the Medicaid expansion is for childless adults. Well, not in Texas, because we only cover a tiny, tiny subset of working poor parents in Texas. So we're not only excluding other working age adults in our Medicaid program, which is part of the flaw of the federal law for Medicaid, but we're also excluding almost all the parents of our working poor kids. Just going to show you a couple of things. This comes up quite a bit. There is a very strong disparity in the impact of the uninsured and of the Medicaid expansion with respect to Hispanics in Texas. Again, I did a Hispanic forum recently, and they asked me to bring some of these as a Kaiser Family Foundation slide, but you can see that in Texas, 38% of our uninsured are Hispanic compared to 32% nationwide. And I'm sorry, that's not right. Not 38% of our uninsured. 38% of Hispanic Texans are uninsured, and 32% of Hispanics nationwide are uninsured. So very, very high. And when we get, and again, thanks to Kaiser Family for this, when we get to looking at the Medicaid expansion, in Texas, 63% of the adults who stand to gain from the Medicaid expansion are Hispanic Texans, compared to 35% of the low-income folks, adults nationwide, who stand to gain from it. So this is sort of a picture of the coverage gap that we're ending up with because we haven't done the Medicaid expansion. This is the scheme of what coverage is supposed to look like in 2014. So in the children's column, we're still going to have Medicaid, and we're still going to have our Children's Health Insurance Program. And then kids above that income, just like adults, if there's employer-sponsored coverage, that's decent, affordable coverage, that's where they're expected to get it. If not, there's the sliding scale help. If they're above 4 times the poverty level, then they don't get any sliding scale help, but they can buy coverage in the marketplace at full cost and with the same consumer protections that anyone else would get. On the adult side, our problem is that because the Medicaid piece of the coverage scheme in the Affordable Care Act was not written to be, was not conceived to be optional. No one, I promise you, in their wildest dreams thought the Supreme Court would do what they did. It was completely unexpected. And so basically they didn't even strike the language in the bill. So the law literally still says every state's going to do this Medicaid for adults up to 138% of poverty. What the Supreme Court did was say, any state that doesn't do it, there's no penalty. And so it effectively makes it optional, and we have a law that says that the sliding scale help in the marketplace doesn't start until you get to the poverty line. So literally, the person at 95% of poverty who's a parent has no coverage in January, and the person at 105% of poverty does. That's where this situation leaves us. Now, we did some work with Methodist Healthcare Ministries and with Dr. Steve Murdoch and Dr. Michael Klein here at Rice University. Dr. Murdoch used to be the head of the U.S. Census under George Bush and also was our first Texas state demographer. He estimated, and he did this research before the Supreme Court's ruling, so he wasn't trying to set up a talking point for me, but he basically did an analysis of the coverage gains and unfortunately projects that about half the coverage gains in Texas depend on us doing the Medicaid expansion. So basically what he's saying is if we have just sort of so-so moderate take-up in Texas, we should cut our uninsured rate in half, but unfortunately half of that half depends on the Medicaid expansion. So we will be leaving half our coverage gains on the table if we don't do the expansion. Now, why is anybody even talking about this in such a conservative state? Not only are the numbers of people potentially covered, but the dollars are phenomenal. You can see in the title of this slide, we're talking about $6 billion a year every year from 2014 to 2017 on average. It obviously ramps up a little bit, but that's what the Medicaid agency estimates the additional health care spending in Texas would be. And so it has huge implications. You can see Harris County would be looking at almost $1 billion more in health care spending for people who are uninsured today, essentially, and who are being paid for by the local taxpayers through their property tax dollars as their hospital district, like our Central Health, takes care of their health care. And you can see the Travis County number. But look at South Texas. Look at Bexar County, $500 million a year. Look at Hidalgo County, $400 million a year. I promise you that is a lot of money in the Rio Grande Valley's economy. And so, you're not only taking away an opportunity to provide a whole lot of coverage in a part of Texas where a whole lot of people work and are in poverty. You're taking away the opportunity for them to be covered, and you're taking away the opportunity for their community to have this economic development. Can we afford it? Yes. One of the things that we've done here in Texas is we have cut what we're spending in Medicaid. So if you adjust for inflation, we are actually spending almost $1,000 less. Well, that's in federal funds. In Texas funds, we're spending about $500 less per person on Medicaid than we were over a decade ago because we have done so much cost cutting. And so basically, the take-home there is the Medicaid expense that Texas is experiencing is not because we're spending too much per person or not being thrifty there. It's because we have so many uninsured people. Medicaid's cost per person has grown at a dramatically lower rate than Medicare's, and Medicare has grown at a dramatically lower case per person than people with private insurance in the United States. So we're not the Lone Ranger on Medicaid expansion either. You can see all of these light blue states except Ohio, which crossed the line after September 30th when this slide was made, are also not doing Medicaid expansion. So I just wanted to tell you we're talking about around 1 million people. There's different estimates from different sources, but they're all around 1 million U.S. citizen adults who are uninsured today, who are leaving without a coverage option in January. And what that means is that, again, like I said before, in January, one parent with 2 kids living on $18,000 will have no coverage. Her next-door neighbor with 2 kids living on $20,000 will. Or another way to look at it is the mom with 2 kids living in Lamesa and living on $18,000 won't have any coverage, but her cousin over in Hobbs, New Mexico, living on the same amount of money will, because New Mexico, with a Republican governor, is doing the Medicaid expansion. So I've left you some, we'll leave this slide up in case you want to take a gander at those, but you can get to all of these groups, all of these websites with information about people who are working on health, on Medicaid expansion and on ACA implementation through the cppp.org website. We have links to all of those. And I probably should turn it over to Bonnie for questions.
Raise your hands high, and I'll bring the microphone to you.
With respect to the fact that now we're going to have a whole lot more people, at least we hope, being insured, the insurance companies are going to have skin in the game in a lot of cases where they did not. And those are cases where the charges for the medical services through things like ChargeMaster, etc., created 5, 10, 20 times the charges that were actually paid by insurance companies that were in the deal. Now the insurance companies are in the deal. Mm-hmm. What effect is this going to have, number one, on the providers and the games that have been played with the charging systems, and on the insurance companies that are now, because they're in the private sector, motivated to realize more profit or more surplus income? What effect is that going to have?
Well, I wish I knew the answer to that, but I think that that was a wonky question. I'm going to try to see if I can give it a... So basically, one of my favorite graphics that, I could take 10 minutes trying to find it for you, but I'm just going to tell you about it, is a bar chart that shows you how much is spent per person in the United States and then all of the other industrialized countries that are in the OECD. And you may have seen it before, and it's like we're around $8,000 a person. And the next closest one, which I think is Norway or Sweden, is around $5,300. So we have huge issues, and the New York Times has done just a smashing series over the last 5 months or so in the Sunday, and you can read them online. It's worth going back and looking at some of these pricing issues, showing a guy who the best deal he could cut on a replacement hip was $13,000 for the hip itself, ended up going to Belgium and having the entire procedure and all of his lodging and transportation all done for less than $13,000. So we have huge issues with pricing and a really distorted market in the United States, and we have huge challenges because everyone who's making profit is going to try to hold on to their profit. And to be fair and honest, even the players that are named as nonprofits and public players, no one walks up and offers to make less money on, or rarely do you see somebody walk up and say, we're going to do fewer bypasses because, by the way, for the last 20 years, the science has shown that it doesn't help many people. And, it's really hard to get those incentives to change. So it sets us on a path to things like accountable care organizations and, only rewarding hospitals and health systems that are avoiding potentially preventable events and readmissions and all those types of things. But it's just the very beginning, I think, of getting that kind of stuff under control. And, the Holy Grail, the problem has always been to find a way to create that both simultaneously an incentive to be cost effective, but also have that pressure to show that you're doing the best thing for people's health and their outcomes. And no one yet has done a great job of doing that, but we know, and some of you have read more about it than I have probably, but some of the articles that Dr. Gawanda has published in the New Yorker have popularized that understanding that there are systems where they're integrating care and looking at outcomes and not just looking at the bottom line, and that sometimes those places do the best care for the least amount of money. So I'm sure there's more to say about that. We can talk about it afterwards.
Yes, I can read a lot of the text on your slides there, so I had difficulty following some of your arguments because it was not clear what there was saying on these slides. Are the slides on your website? Can you
do you guys usually post them somewhere, or do you guys have? I was just going to ask, does the church have a place where they post things? I can make sure they get posted online. We probably through our blog. So if you'll go to the blog at cppp.org, I'll post it. Sorry, CPPP, Center for Public Policy Priorities.org.
We have a question from Peter.
So that I can be prepared for all my Republican relatives at Thanksgiving, can you briefly explain, I think you started to, what is the flat last week about people who can't keep their coverage after all? Is it generally because that coverage doesn't live up to the new standards?
That is correct. It's because it doesn't live up to the new standards, but it's the thing that really set me off, and I was listening to On the Media this morning, and they talked about this, and I thought they kind of blew it. So I wrote them a long comment on their website this morning, and that's not why I was late. But basically, the coverage that's sold through the private marketplace in the individual and small group market, whether it's inside the new marketplace or outside the new marketplace, individual and family coverage and small group coverage, all subject to these new requirements. Plans that existed before the ACA was passed on March 23, 2010, all had the ability to be grandfathered and to keep whatever crummy structure they had. So there was totally an opportunity for people to keep what they had if they liked it. It's only plans that were created after the law was passed and were created with the full knowledge of the insurers that created them, that they were substandard, but apparently without telling any of their consumers that they were substandard and that they would have to either be improved or eliminated in 2014. This is what makes me crazy. It's not like this was closely held information. It wasn't a secret. I knew about it. I've known about it since 2010. I think the insurers knew about it too. And just wish the media would focus on it a little more. It's sort of like, I'm sorry you didn't understand this. The simplest way for you to have understood this would have been for your insurer to have revealed that to you when they sold you a plan that they knew would not meet federal standards in 2014.
We have time for a very quick question. John Franks.
Yeah, I was helping our son on his application, and one question that is asked is, do you smoke or not? Can you comment on that?
That's a big one. If you smoke, I forgot to mention that. So age and smoking and geography are the three rating factors in the new marketplace. Geography is not going to be something you get discriminated on. It's basically, everyone in your geographic area, they'll be looking at actual costs of living and healthcare costs. But on smoking, your premiums can be written up a whole bunch, like I think 50%. And they don't give you an extra subsidy to cover that. So that's where you really get dinged, is if you're low and moderate income, you're qualifying for a subsidy, but you've got this big add-on for smoking, it's really going to eliminate that potential benefit for you or make your coverage much less affordable. So a better reason than ever for people to quit smoking.
And thank you for a very informative and also an anxiety-reducing presentation. I mean, I think this has helped us all. The complexity is mind-boggling, but thank you.